Thank you so much. So this is going to be a lot like Dr. Hadley Wilson's talk about complete revascularization in STEMI, so I have no disclosures. What I thought is we talk about the evolution of to complete revascularization and talk about where we are now, what are the open questions, and what are the opportunities for the future. So as was already stated, about 30 to 50% of STEMI patients actually have additional stenosis in top of the infarct-related artery. And the past guidelines supported the culprit vessel PCI, and obviously you've heard that that's changed. And there are contemporary studies that suggest complete revascularization. I'm going to review that data with you. But there are questions. Should we be doing it at the same time? Should we stage the procedure? And where does imaging and all of that come into place? You saw this slide earlier. This is the data from the Cadillac trial that showed that multivessel disease is associated with worse outcomes. So patients that have triple vessel disease have a higher mortality, and patients with multivessel disease in general have that higher mortality in spite of a primary PCI. So this is the data from the relevant randomized clinical trial. You see that we've been gathering data in this area since almost 2011. The trial that really hit the radar first was PRAMI in 2013. The culprit trial, Danami, Primulti, Compare Acute, Complete, and then the Flower AMI. Those are the big heavy hitters. Culprit shock I just put there, but I'm really not going to be focusing this talk on the shock patients. What I do want you to notice is the number of patients, and PRAMI was 465, culprit was 296, Dana Primulti was 626, relatively small. Our largest trial is the complete trial with over 4,000 patients. And then in terms of the percentage of males, and then also look at the FFR and non-culprit, and I have that in this next slide. Each of these trials, either they're angiographically guided or FFR guided. The first two, PRAMI and culprit, did not use FFR. We did see the use of FFR in Danami, Primulti, as well as the Compare Acute, and certainly both angiographic guidance as well as FFR was utilized in the complete trial. Now, interestingly, the definition of the non-culprit lesion differed amongst the trials, right? Lesions were deemed appropriate for revascularization when they were over 50% in some of the trials. Sometimes it was over 70%, other trials over 80%. And so even when we say angiographic assessment, if you look deeply at these studies, what is angiographic assessment? Is it more than 50%? Is it 70%? And when they did do FFR, what they did was if they were over 70%, they ended up doing angiographic. And if it was less than 50 to 70%, they used FFR to guide it. That was what was done in the complete trial. 4 trials that used the FFR to select lesions, 3 trials used the cutoff point at 0.8, and 1 trial used 0.75 as the FFR cutoff to determine the stenosis. So I think when you look at the totality of the studies, you have to look deeply at what are the cut points that they utilized, because it is hard to make generalizations unless you look at these details. The PRAMI trial, you already heard about this trial. This showed that there was a 65% reduction in the relative risk of the primary outcome, which was a composite of cardiac death, non-fatal MI, or refractory angina. Certainly, complete revascularization did better in this PRAMI trial. Remember, a small trial, but certainly impactful. Culprit trial was the next trial a year later, also showed that in the complete arm, which is below in the green, showed that complete revascularization had a lower rate of MACE, which was the total mortality, recurrent MI, heart failure, and recurrent revascularization. And then if you look at the Danami Primulti, remember they used FFR here. Again, the red is complete revascularization. These patients had a lower event rate than the patients that did not have, just did infarct-related artery PCI. And if you look at the individual components in this, you'll see the composite. The red is the complete revascularization did better. But if you break it down, the non-fatal MI, not a big difference. All-cause death, not a difference. It was really the separation of the curve came with the repeat revascularization. And so there was a lot less repeat revascularization in the complete arm as would be expected. The Compare Acute trial, you've heard about this trial already. Also, the FFR-guided complete revascularization, which is on the top, the blue line did better. The primary endpoint occurred in 7.9% in the FFR-guided multivessel PCI that was done at the time of the primary PCI group, and the endpoint in the patients with culprit artery, it was 20.5%. Again, all this data accumulating year after year that said that complete revascularization is what we need to be thinking about. This was a meta-analysis done in 2016, published in JACC, that looked at all of the trials, and except for the Prague 13 trial, which was sort of the outlier, most of them favored complete revascularization. Remember, so multiple studies were performed to look at complete revascularization in patients presenting with STEMI. But as I mentioned to you, these studies use different technologies, revascularization strategy, and they achieved complete revascularization during the index PCI, during the index hospitalization, or after discharge. And they had variable results and conclusions. Most of these studies were small, did not have the statistical power to really assess the hard endpoints, such as reinfarction or mortality. And so these variable combinations were also looked at in multiple meta-analyses and sometimes giving its conflicting results. But what did become clear in spite of all of this was the fact that we changed the guidelines. So based on at least the DANA, multi-culprit, and even PRAMI, the class 2-3 recommendation, which previously was there, was changed to a 2B recommendation and upgraded based on these trials. Remember, this was even before COMPLETE came out. Now, I'm not really going to talk about shock, and Dr. Wilson already addressed this, but the culprit shock data showed sort of opposite. It actually showed that targeting just the infarct-related artery, they did better, not only for all-cause mortality, but in terms of the primary endpoint. And of course, as you would expect, the one-year repeat revascularization was higher in the group that had the culprit lesion-only vessel PCI. So the big granddaddy of all the studies in terms of complete revascularization was the COMPLETE trial. This was the 4,000 patient trial, and this looked at almost 2,000 patients in the complete revascularization arm, and then culprit-only vessel was also another 2,000. And if you look at the primary outcome, whether you like to see it graphically or with numbers 7.8 versus 10.5, so blue is complete revascularization, the yellow graph is culprit only, and then of course there was also a difference when you looked at the secondary outcomes in this particular trial. So putting all of this together, JACC had another meta-analysis. This was multi-vessel versus culprit-only revascularization in STEMI and multi-vessel coronary artery disease. And so this looked at all of the trials. And what they did was they looked at the 10 trials that randomized STEMI to complete versus culprit-only revascularization. It included almost a total of 7,000 patients. Almost 3,400 of them received complete revascularization. And they either had it during the index procedure or the stage procedure, and 3,600 had complete-only revascularization. Now, interestingly, the results were quite compelling. It demonstrated a lower risk of cardiovascular mortality, and I highlight cardiovascular mortality. Why? Because ultimately, there was no difference in terms of all-cause mortality, and that's always been something that we've thought about. Why do we not see a difference in the all-cause mortality? And then, of course, a lower rate of reinfarction, as would be expected, and decrease in the repeat revascularization with the complete revascularization versus complete-only culprit-only revascularization. But these are the questions that remain, and some of these, again, Dr. Wilson highlighted. How do you select the non-culprit lesion to be revascularized? What is the cut point to decide which lesion to revascularize? Remember, the trials use that angiographic stenosis greater than 50%. And so, or an invasive functional study to determine the need for a PCI. So we need, collectively, I think most people feel if it's over 70%, then you can consider doing the PCI, but if it's less, between that 50 to 70%, FFR guidance may be helpful. This is where the Flower AMI trial, this was also a trial that you just saw with Dr. Wilson, and it showed that patients that underwent primary PCI and had non-culprit multi-vessel disease, FFR-guided revascularization was not superior to angiographically guided revascularization. But again, I think that you have to look at the cutoff points, and most people would argue if it's over 70% angiographically, but maybe still use FFR to help us with the other part. So another question, what is the best time of revascularization for a non-infarct-related artery? Is it during the index PCI? Is it in a two-stage strategy? Or is it after discharge? Well, the meta-analysis partially answered it, showing that a possible benefit for complete revascularization during the index procedure versus waiting and doing a staged procedure. At least that's what this particular meta-analysis. What about the role of IVUS? During the first session, we talked about imaging. Is there a role for IVUS? Well, Greg Stone and his group demonstrated that IVUS can really assess plaque instability. So the plaque burden, the cap thickness, the lumen area are all signs of plaque instability. And the risk of future cardiovascular events when those plaque unstable features are there, those patients are more vulnerable for cardiovascular events at 3 years, even if they were angiographically mild at baseline. So assessment of plaque instability with intravascular imaging could play a role in future trials to really determine whether the outcome of complete revascularization versus infarct-related artery PCI alone. So I think besides determining plaque instability, intravascular imaging has been shown to improve PCI outcomes. We talked about that at length earlier. And could the outcome of these studies be changed by using a PCI guided by IVUS imaging, particularly doing complex multi-vessel PCI? The other thing to remember is that most of these trials tended to choose, the syntax score on these patients was lower. If you look at the complete trial, those patients were not the most complex patients, so complex multi-vessels were usually excluded in these trials. So I would say nearly half of the patients presenting with STEMI at least have other obstructive lesions in a non-culprit vessel at the time of their index PCI. I think the present data clearly shows that multivessel revascularization is associated with a lower risk of cardiac mortality and reinfarction without any difference in all-cause mortality. I think future research should evaluate the optimal timing of non-culprit vessel revascularization, although it appears that during the index hospitalization seems to be the right time. But I think the future holds promise for using IVUS to better assess the plaque stability and for improving outcomes. So thank you very much for your attention.